Are rural patients with diabetes mellitus adequately screened for diabetic retinopathy in a primary care setting? Hello, my name is James White and I'm a final year medical student at the University of Notre Dame, and I conducted this audit with the help from my supervisor, Dr. Stu Adamson. This is an important issue as diabetes is a serious disease that is very prevalent in our society, and if undiagnosed and untreated, it can lead to many serious consequences. One such consequence of the disease is diabetic retinopathy, a form of vision loss or blindness. Although there is no cure for this vision loss, it is preventable, and if we implement adequate screening in the primary care setting, it's possible to minimise the associated damage. I was pleased to be part of this project in hope that I can contribute toward positive health outcomes, but also I have a passion for rural and regional health, and I'm keen to highlight the notable discrepancy between healthcare of patients in regional areas to those of metropolitan areas. A little bit about the disease, just stripping it back to basics. I've included type 1 and type 2 diabetes in this. Type 1 often presents earlier in life and has to do with insufficient production of insulin. Type 2 usually later in life but is presenting earlier. It's associated with insulin resistance and can progress to a state where also insulin isn't produced. Around the world, it's estimated that 1 in 11 adults have diabetes, and 1.7 million Australians were reported to have diabetes in 2012. No doubt that has since escalated. Focusing on diabetic retinopathy, up to 35% of diabetic patients have reported some form of vision loss, and it's the leading cause of new onset blindness in the Western world. This audit is to do with screening for retinopathy. Now, this is important. A 2016 report showed that up to 98% of vision loss can be prevented if we identify it early, by screening for it, if we implement treatment and monitor the management. What I have set out to do in this audit process is to assess for those patients who are currently on a diabetic management plan, are they having their eyes checked every 2 years? There are guidelines set out by the Australian Diabetes Society, and they've been published by the National Health and Medical Research Group, the NHMRC, also by the Royal Australian College of General Practitioners. These guidelines recommend screening every 2 years. I've assessed this against the published standard. The published standard states that persons with diabetes should have a dilated fundus examination by a trained examiner with adequate sensitivity and specificity at the time diabetes is diagnosed and at least every 2 years. By assessing it against this standard, we're presuming that the standard is implying that 100% of people who fall into this category should be screened. So what I'm aiming to do, I'd conducted this audit at a rural GP medical centre, and I went through their diabetic patients and I was assessing if they had been screened according to these guidelines. My aim wasn't to find the shortcomings or the faults in the system, but more to assess if it's being done, find out where it can be improved, and by feeding that information back, and hopefully by doing that, improve the quality of care and the patient health outcomes. I undertook this clinical audit at a GP medical centre in a regional town. The town is situated 420 kilometres outside of Perth and has a population of 40,000 people. The Department of Health published statistics in this area. There 7% of the town were diabetics, which was higher than the Western Australian average of 6.3%. The practice itself reported having approximately 450 diabetic patients. The medical practice where I performed this audit had 9 doctors and 4 nurses. They had a database system and they had very well organised records. These patients who were diabetic had a diabetic identifier placed against their name, which made it very easy for me to extract the information. I went into the database, and with assistance from the administrative staff, I chose the last 3 months that I was there, assessed the diabetic patients who had come in and used these as part of the inclusion criteria. Then I went through those patients, and if those patients hadn't been with the practice for more than 2 years, or if their diagnosis of diabetes was less than 2 years old, or if there was evidence that they were not regular at that practice and had been seen by other GPs, then those patients were excluded from the audit. I went back and took the last 63 diabetic patients to attend the practice. 13 of these were excluded and 50 of them were included. With those 50, I extracted the data and downloaded automatically the information, these biomarkers that you can see here. I then went through manually and went through their attached paper records just to make sure that they had a diagnosis of diabetes for more than 2 years. I also looked for if they'd been referred to an eye specialist in the past 2 years. Now, an eye specialist in this regard was either an optometrist or an ophthalmologist, somebody who was trained in dilated fundus exam. And I also looked if a letter had been sent back to the practice from one of these specialists saying that that the patient had an exam. Now, getting to the exciting part, the results. Thanks for staying with me. Of the patients examined, 50% were male and 50% were female, split right down the middle. Where of those, 84% were recorded as non-insulin dependent diabetics, and 16% were recorded as insulin dependent diabetics. Now, that was interesting. I think some of the problem here was the diabetic identifier. The non-insulin dependent diabetes was the previous form of type 1 diabetes, and I'm not sure if some of the type 2s who'd progressed to needing insulin had been recorded as insulin-dependent diabetics. That might be more an issue of the recording and extracting the data, because the 16% you see there, the national average is closer to 8%, so that's a little bit higher, but that's something that we can look at. Now, referred for fundoscopy in the last 2 years. Obviously, we're hoping at getting as close to 100% as possible. Only 26% of those diabetic patients had been referred for a fundoscopy to a specialist in the last 2 years. And of those patients, 36% had received a letter from a specialist back to the practice to say that they had had an examination. Now, if we look at those patients, the 13 of the 50 that were referred, all of those were referred to the local ophthalmologist, and the patients who had received an examination, who had completed an examination, 18 of those patients, we can see that 7 of those were from the ophthalmologist, and there were 3 local optometrists which completed the others. Interestingly, the 7 from the ophthalmologist, only 3 of those had been sent, were patients where the GP practice had sent a referral. Most of them were patients that the ophthalmologist had seen for other reasons, whether it be post-surgical or for other reviews. So the referrals and the examination were not aligning in that regard. The other piece of information I pulled was each of these patients were put on a diabetic care plan. On that diabetic care plan was a list of specialists, and 37 of the patients had an eye specialist included on that plan, but 13 did not. So that was interesting to note as well. Now, we set out to see how many patients were being screened, set against our standard, which we were going for over 100%. We know that is not always practically possible, and so it's interesting to have a look at some of the reasons why that hasn't been put in place. So we're just going to analyse the data. There's only the one ophthalmologist in this town, and they have not been seeing patients for screening. They're only doing emergency and surgical and post-surgical follow-ups. So that's obviously falling down at that point. And it seems that this has been going on for some time. So I imagine that if the referrals are being sent out but they're not receiving that feedback, then the motivation to continue doing referrals would wane. Many of the examinations that are done, in fact the majority of them were done by local optometrists, so that's an interesting point that we should look into. And something that one of the principal doctors at the practice, Dr. Borchards, talked to me about was a study to show that if we were actually spending all of our time on screening, performing all the different screening tests, then there actually wouldn't be any time to do anything else. So in some regards we have to assess just how important this is to these patients, and whether or not we're going to how much we're going to prioritise this particular test. And the other thing is, many of these patients are quite frail and they have many other comorbidities going on, and there are some other things that we have to prioritise. And finally, there's a patient motivation. Not all of the patients are that keen to follow up on appointments, and so that might be something that we can change. Now, there was a 2015 report which asked GPs how well they're doing. It is self-reporting, and 91% of GPs stated that they referred diabetic patients to ophthalmologists every 1 to 2 years, and 68% of them said they referred them to an optometrist on the first diagnosis. Obviously, as I mentioned, that is self-reported, and so that may be a little generous, but just something to keep in mind. After discussing these results with the principal doctors, there were some recommendations made, and these are some of the ideas. Obviously, the referrals to the ophthalmologists have not been quite productive, but the optometrists seem to be quite good in staying on top of their patients. So maybe even include the optometrist into the care plan and send the referrals to the optometrist instead of the ophthalmologist. Communicate with the optometrist and find out what is their recall process, and can this be assisted by the GP practice as part of their plan, and also just looking at different factors affecting patient motivation, and finding if there are any methods to help the patients want to attend their appointments. We can make a plan around that, do a follow-up audit in 2 years, and then assess if there's been any improvement, and then feed that back. There were some limitations around this audit. This was the first time audit at this practice. This was also my first audit that I've undertaken, so obviously there is a slight chance that there is the potential for human error along the way. Obviously there are recording issues. The records have to be recorded in order to be extracted. So there are several steps along the process where this audit could fall down. The diabetic identifier wasn't always specific, as we mentioned with the insulin-dependent diabetes, and this audit was also only of 50 patients. So in order to create a more reliable statistic, we could do it with more patients, we could do it also with more practices, and have a much wider scope for a more robust statistic. I'd like to say a very, very big thank you to the practice, to my supervisor, also to the principal doctors, the practice owners there, the administrative staff who were amazing at helping me access the information. There is a nurse who specialises in diabetics on site who was very helpful, but also all of the doctors and nurses and all the staff on site were very helpful, and really helped me enjoy my time there. And here are some references which are exciting as well. Thanks very much. Bye.